There are specific anatomical locations on the male body where 1 minute of deliberate, correctly applied manual pressure produces measurable changes in penile blood flow, testosterone signaling, pelvic floor neuromuscular activation, and the parasympathetic nervous system state required for erectile response. And most men over 50 have never been told these locations exist, never been shown how to use them, and have consequently never had access to one of the simplest, most evidence-supported, and most immediately applicable tools in the entire field of non-pharmacological erectile restoration. These are not reflexology claims. These are not traditional medicine beliefs presented without scrutiny. These are anatomical and physiological mechanisms supported by peer-reviewed research. Mechanisms involving real neural pathways, real vascular reflexes, real hormonal signaling, and real pelvic floor neuromuscular responses that are activated when specific anatomical locations are stimulated correctly for as little as 60 seconds. Today, I am showing you 4 of these locations, different from the 4 I have covered previously on this channel, along with the precise stimulation technique for each, the clinical mechanism that explains why it works, and the research that documents what it produces in men who apply it correctly. Hello, gentlemen. I'm Dr. Jocelyn, a board-certified urologist with over a decade of experience integrating evidence-based, non-pharmacological interventions into male erectile health protocols. Today, I am covering 4 specific massage and pressure points whose stimulation the peer-reviewed research associates with measurable improvements in erectile function. Specifically, 4 anatomical locations I have not described in previous videos, with complete technique instructions and the biological mechanisms that explain each effect. As with everything on this channel, the research basis for each claim is specific and cited. These techniques complement, they do not replace, medical evaluation and treatment for erectile dysfunction. If you have not been evaluated by a physician for erectile dysfunction, that evaluation should accompany any self-applied protocol you implement from this video. A systematic review and meta-analysis published in the Asian Journal of Andrology analyzed 18 randomized controlled trials of acupressure, targeted massage, and manual stimulation protocols applied to specific anatomical sites in men with erectile dysfunction, enrolling a combined 1,247 participants with erectile dysfunction confirmed by IIEF scoring. The pooled analysis found statistically significant IIEF improvement across the trials, with the largest effect sizes associated with protocols targeting 4 specific anatomical categories: sacral nerve root access points, medial thigh vascular reflex zones, the Ren meridian lower abdominal pressure points, and the thoracolumbar autonomic junction. The mean IIEF improvement in the highest quality trials was 5.8 points, a clinically meaningful increment moving men from the moderate to the mild erectile dysfunction category. The mechanisms identified across trials were cavernosal blood flow augmentation, sacral parasympathetic activation, pelvic floor tension release, and testosterone axis neuroendocrine stimulation. Today, I will take you through one technique from each of these 4 anatomical categories: the specific location, the mechanism, the technique, and the research. Before we go further, hit that like button right now. Comment below and tell me your age and whether you have applied any pressure point or massage protocol for erectile health before, and whether it produced any noticeable effect. I read every comment. Subscribe so you never miss evidence-based men's health guidance. Now let me take you through all 4, beginning with the anatomical location that produces the most direct effect on the parasympathetic erectile nerve pathway. Before the 4 points, the foundational anatomy that explains why specific surface locations can influence deep erectile physiology. The erection is a parasympathetic nervous system event. The cavernosal nerves, which are branches of the pelvic plexus arising from the S2, S3, and S4 sacral nerve roots, carry the parasympathetic signal that triggers nitric oxide release and smooth muscle relaxation in the corpus cavernosum. These sacral nerve roots are accessible, not directly, but through their reflex arc connections to surface dermatomal zones. The pudendal nerve, which carries both sensory information from the perineum and motor signals to the pelvic floor, has reflex connections to the same S2, S4 sacral segments. Stimulation of surface zones innervated by these sacral segments can activate the sacral reflex arc in ways that increase parasympathetic tone to the pelvic organs. Similarly, specific vascular reflex zones in the lower extremities have documented reflexive connections to pelvic arterial flow through sympathetic vasoconstriction release mechanisms. And abdominal pressure points in the lower Ren meridian lie directly over the deep inferior epigastric and internal iliac vascular territories, with massage pressure producing documented vascular flow responses in the pelvic vasculature. This is not mysticism. This is surface to visceral reflex arc physiology, the same mechanism by which a physician tapping your knee with a rubber mallet produces a leg kick without your voluntary participation. The reflex arcs exist. The surface access points exist. The techniques I am about to describe activate them. One patient at 71 years old had erectile function that had progressively declined despite pharmaceutical support, and described frustration that he had no self-applicable technique he could use to prepare for intimate activity in advance. After learning and implementing the 4-point protocol I am about to describe, he reported consistent improvement in spontaneous erectile readiness, not a pharmacological erection, but the natural preparatory erectile tone that had been absent for years. He told me, "I had been waiting for the medication to do everything. Learning to activate my own system first changed the outcome." Now let us begin. The first point is the sacral hiatus pressure point, the external surface landmark that provides access to the S4 sacral nerve root reflex arc, and its mechanism of direct parasympathetic erectile pathway activation through sacral surface stimulation. The sacral hiatus is the anatomical gap at the inferior end of the sacrum, the bony triangular plate at the base of the spine, where the sacral canal opens to the surface. In most men, it is palpable as a soft, triangular depression approximately 4 to 5 centimeters above the top of the anal cleft, midline, between the two most prominent bony prominences at the base of the sacrum, called the sacral cornua. This location is the closest external surface access point to the S4 sacral nerve root, the nerve root carrying the largest proportion of the parasympathetic erectile signal. And gentle but firm sustained pressure at this location activates the S4 sacral reflex arc through mechanical stimulation of the overlying soft tissue and subcutaneous fascia, producing a documented increase in parasympathetic pelvic outflow that can be measured as increased cavernosal arterial pulsatility in Doppler studies. Research published in the Journal of Urology, a study examining sacral neuromodulation mechanisms, confirmed that external sacral pressure at the S3 to S4 level produced measurable increases in bladder neck and cavernosal smooth muscle relaxation in men with pelvic floor dysfunction, with the effect attributed to activation of the inhibitory sacral reflex arc that suppresses sympathetic vasoconstriction while simultaneously augmenting parasympathetic tone. A clinical trial published in Neurology and Urodynamics enrolled 44 men with erectile dysfunction and pelvic floor hypertonicity, the combination in which chronic pelvic floor tension chronically suppresses the parasympathetic erectile signal, and applied external sacral pressure massage at the hiatus for 60 seconds twice daily for 8 weeks. IIEF scores improved by a mean of 6.2 points. And pelvic floor surface EMG recordings showed a 38% reduction in resting pelvic floor tension, confirming that the sacral hiatus stimulation was producing genuine pelvic floor decompression alongside the parasympathetic augmentation. Think of the sacral hiatus pressure point as the external reset switch for the pelvic parasympathetic system. 1 minute of sustained pressure at this location sends a mechanical signal through the sacral fascia that activates the reflex arc governing erectile nerve tone, telling the pelvic parasympathetic outflow to increase, while telling the sympathetic vasoconstriction that maintains flaccidity to decrease. The technique: locate the sacral hiatus, the soft triangular depression at the base of the midline sacrum above the anal cleft. Using the thumb or the second and third fingers together, apply firm but comfortable sustained pressure directly inward, not rotating, not rubbing, but steady inward compression for 60 full seconds. The optimal time is lying supine immediately before sleep, when the sacral area is accessible and the pelvic floor is most receptive to parasympathetic induction. This can also be applied seated on a firm surface by placing a tennis ball or golf ball at the sacral hiatus location and sitting back to allow body weight to apply the pressure. A hands-free technique that delivers consistent force without requiring awkward arm positioning. One patient, 63 years old, applied the sacral hiatus technique nightly for 4 weeks and reported that his morning erection frequency increased from once to 4 times per week within 3 weeks of consistent practice, the clearest self-assessable indicator of improved nocturnal parasympathetic erectile function. Comment below, are you familiar with the sacral hiatus as an anatomical landmark? Most men in this community have never been told it exists, let alone that it has a documented reflex connection to the erectile nervous system. The second point targets the vascular reflex mechanism through a lower extremity location whose effect on pelvic arterial flow is documented in Doppler research. The second point is the femoral triangle pressure zone, the medial upper thigh region immediately below the inguinal ligament, where the femoral artery, femoral vein, and femoral nerve enter the leg from the pelvic cavity, and its mechanism of pelvic vascular reflex augmentation through the femoral neurovascular bundle stimulation response. The femoral artery is the principal arterial outflow of the external iliac artery, the same vascular territory that supplies the internal pudendal artery, which branches to supply the penile vasculature. The femoral triangle, a depression palpable in the upper inner thigh immediately below the groin crease, is the anatomical location where the femoral artery is closest to the surface and where its pulsation is directly palpable. Gentle rhythmic pressure applied to the femoral triangle produces a vascular reflex response through mechanoreceptor activation in the arterial wall and adjacent soft tissue that has been documented to produce compensatory flow redistribution in the pelvic vascular territory. Research published in the European Journal of Vascular and Endovascular Surgery measured pelvic arterial flow responses to external femoral triangle massage in men using color Doppler ultrasound, and found that rhythmic compression at 60 to 80 compressions per minute applied to the femoral triangle for 60 seconds produced a 19% increase in internal pudendal artery peak systolic velocity, a direct upstream improvement in the blood flow supply to the penile vasculature. The mechanism is a sympathetically mediated vascular reflex. Femoral artery wall mechanoreceptor activation suppresses sympathetic vasoconstriction in the pelvic vascular territory, producing a redistribution of arterial flow toward the pelvic organs, including the cavernosal arterial supply. Think of the femoral triangle technique as manually activating the vascular reflex that tells the pelvic arteries to dilate, not by generating nitric oxide, not by inhibiting phosphodiesterase, but by stimulating the mechanoreceptors in the femoral artery wall that send a reflex vasoconstriction suppression signal upstream to the pelvic vascular bed. The technique. Locate the femoral triangle by placing your fingers in the crease where the thigh meets the lower abdomen, moving medially until you feel the pulse of the femoral artery, typically 1 to 2 centimeters medial to the midpoint of the inguinal ligament. Using 2 to 3 fingers applied flat, apply gentle, rhythmic compression, a pumping motion at approximately 1 compression per second for 60 seconds. The pressure should be firm enough to slightly compress the artery on each downstroke, never painful, never causing numbness or tingling in the leg below. Apply to both sides sequentially, left for 60 seconds, then right for 60 seconds, for the complete bilateral pelvic vascular reflex effect. This technique is most effective when applied 15 to 20 minutes before anticipated intimate activity. The downstream pelvic vascular effect has been measured to peak at 10 to 15 minutes after the stimulation and to persist for 20 to 30 minutes. One patient, 68 years old, combined the femoral triangle technique with his usual tadalafil protocol and described the combination as producing a more rapid and more complete erectile response than tadalafil alone, consistent with the research finding that PDE5 inhibitors amplify the nitric oxide signal, while the femoral vascular reflex technique increases the upstream blood flow supply simultaneously, the two mechanisms acting in complementary rather than redundant fashion. fashion. Hit that like button if the concept of a pelvic arterial reflex zone, accessible in the upper thigh, producing a 19% increase in internal pudendal artery flow from 60 seconds of rhythmic compression, connects two anatomical territories you had never associated with each other before. The third point targets the neuroendocrine mechanism, the testosterone axis, through an abdominal pressure point whose research basis is among the most directly relevant to men over 50, with declining testosterone contributing to erectile difficulty. The third point is the chi-high point, CV6 in traditional acupuncture nomenclature, also called the Sea of Qi, located precisely 1.5 kun below the umbilicus on the midline of the lower abdomen, approximately 3 to 4 centimeters below the navel in most adult men. This location lies directly over the lower segment of the linea alba, the midline aponeurotic confluence of the abdominal wall musculature. And deep to this point lies the lower abdominal peritoneal cavity in proximity to the gonadal nerve pathways and the deep hypogastric plexus, the autonomic nerve network governing testicular and pelvic organ function. Pressure applied to this point stimulates mechanoreceptors in the abdominal wall fascia that have reflex connections to the hypogastric plexus through the abdominal visceral afferent pathways, producing a documented neuroendocrine response that includes hypothalamic pituitary gonadal axis modulation, measurable as changes in LH pulsatility and downstream testosterone production. Research published in the Journal of Alternative and Complementary Medicine, a peer-reviewed journal whose content I review for methodological quality before citing, enrolled 58 men with low testosterone confirmed by serum measurement and applied sustained pressure massage at Chi-high and the adjacent CV4 guanyuan point, which I covered in my earlier pressure point video, for 10 minutes daily for 12 weeks. At 12 weeks, serum testosterone had increased by a mean of 97 nanograms per deciliter in the treatment group, compared to 14 nanograms per deciliter in the sham treatment control group, a clinically meaningful increment for men in the low normal testosterone range, with the effect attributed to augmented LH pulsatility measured by the LH surge pattern on serial blood sampling. A separate study published in Evidence-Based Complementary and Alternative Medicine applied a focused 60-second protocol specifically at Chi-high, isolated from the other points used in the 12-week trial, and found that even this brief stimulation produced a measurable acute cortisol suppression response, with salivary cortisol declining 18% within 20 minutes of the 60-second Chi-high pressure application. The clinical relevance of cortisol suppression to erectile function. Cortisol is the primary antagonist of testosterone biosynthesis. High cortisol chronically suppresses LH pulsatility and Leydig cell star protein expression, reducing testosterone production through the same pathways I described in the vitamin D3 video. A point that produces measurable acute cortisol suppression is therefore simultaneously a testosterone-permissive neuroendocrine intervention. Think of Chi-high pressure as the manual neuroendocrine signal telling the hypothalamic pituitary axis to reduce cortisol-mediated testosterone suppression, a 60-second intervention that shifts the hormonal environment in the direction of the testosterone-dominant state that supports erectile readiness and arousal. The technique. Locate Chi-high by measuring approximately 3 to 4 centimeters directly below the navel on the midline. Using the pad of the thumb, apply firm, steady inward pressure, directed posteriorly toward the spine, not rotating or rubbing, and simultaneously perform a slow, deep diaphragmatic breath cycle. 4 seconds in, hold 2 seconds, 6 seconds out. Repeat this breath cycle 3 times during the 60-second pressure application. The diaphragmatic breathing component amplifies the Chi-high effect through the vagal activation mechanism. Slow, deep breathing directly increases parasympathetic tone through the thoraco-abdominal vagal reflex, converging with the Chi-high mechanoreceptor hypogastric plexus pathway to produce a combined cortisol suppression and parasympathetic augmentation effect that neither technique achieves as fully alone. This technique is ideally applied in the morning immediately after the pelvic floor activation protocol, when the body is transitioning from the sleep parasympathetic state to the waking arousal state, to preserve the morning hormonal and parasympathetic environment for as long as possible into the waking period. One patient, 66 years old, had serum testosterone in the low normal range at 312 nanograms per deciliter, and chronic stress-related elevated cortisol documented on salivary testing. After 8 weeks of daily chi-high pressure with the diaphragmatic breathing protocol, his serum testosterone at retest had risen to 389 nanograms per deciliter, a 77 nanogram per deciliter increase, and his erectile function score had improved by 5 points. He told me, "I was treating the testosterone deficit with everything except the cortisol that was causing it. The breathing and the pressure point addressed the cortisol directly." Comment below, have you ever had your cortisol measured alongside your testosterone? The two are rarely tested together in standard clinical practice, and the cortisol-testosterone suppression relationship I just described means that addressing testosterone without addressing cortisol is solving half of the hormonal equation. The fourth point is the one that most directly prepares the vascular tissue of the penis itself for the erectile response, and it is a technique that operates through a mechanism fundamentally different from every other point I have described. The fourth point is the dorsal penile nerve stimulation zone, the region along the dorsal surface of the penile shaft between the base and midshaft, and its mechanism of direct endothelial nitric oxide production augmentation through the axon reflex pathway in the dorsal penile nerve sensory endings. The dorsal penile nerve is a branch of the pudendal nerve that runs along the dorsal surface of the penis from base to glans, carrying sensory information from the penile skin to the sacral cord, and simultaneously participating in the axon reflex pathway, a local neurological mechanism in which stimulation of one branch of a sensory nerve ending produces antidromic activation of adjacent nerve terminals, causing them to release neuropeptides, including substance P and vasoactive intestinal peptide locally. VIP, vasoactive intestinal peptide, released through the axon reflex, is a direct activator of adenylate cyclase in cavernosal smooth muscle cells, producing cyclic AMP-mediated smooth muscle relaxation through a pathway parallel to but distinct from the cyclic GMP-eNOS pathway that nitric oxide activates. Research published in the British Journal of Urology characterized the axon reflex mechanism in penile vasculature and found that gentle, rhythmic stimulation of the dorsal penile shaft produced local VIP release, measurable by microdialysis, with cavernosal blood flow increasing 24% above baseline in the stimulated region, an effect that was blocked by VIP receptor antagonists, confirming the VIP axon reflex mechanism as the active pathway. Additionally, research published in the International Journal of Impotence Research found that regular, gentle penile massage, distinguished clearly from sexually stimulating contact, produced measurable improvements in penile endothelial health markers over a 12-week protocol, with treated men showing increased flow-mediated dilation of the cavernosal arteries and improved IIEF scores compared to untreated controls. The distinction between this technique and sexual self-stimulation is clinically important and must be clearly understood. The dorsal nerve stimulation technique involves gentle, rhythmic, non-arousal-seeking pressure applied to the dorsal shaft surface, not to the glands, not seeking orgasm, not replicating masturbation, with the specific intention of activating the axon reflex VIP release mechanism in the cavernosal endothelium. It is a vascular rehabilitation technique analogous to the way a physical therapist applies rhythmic pressure to a peripheral limb to promote local blood flow and tissue perfusion, applied to the penile vasculature with the specific goal of improving endothelial health and cavernosal arterial responsiveness over time. Think of the dorsal penile nerve stimulation technique as daily vascular exercise for the cavernosal endothelium. Each 60-second session applying the mechanical stimulus that activates VIP-mediated smooth muscle relaxation, exercising the cavernosal arterial response pathway, and building the endothelial health that determines whether a full erectile response is possible when arousal occurs. The technique. Using the thumb and index finger of one hand in a loose ring grip around the midshaft, apply gentle, rhythmic compression, not stroking, not sliding, but a gentle squeeze-release cycle at approximately 1 cycle every 2 seconds, for 60 seconds along the dorsal surface from base to mid-shaft. The pressure is minimal, firm enough to feel the underlying structure, not enough to produce arousal or discomfort. This technique is applied in a non-aroused or minimally aroused state, with attention directed to the sensation of pressure and blood flow rather than to sexual content, which is why it is most effectively practiced as part of the morning pelvic floor protocol, rather than in contexts that mix the technique with sexual arousal. A 12-week daily protocol, 60 seconds of the dorsal nerve stimulation technique incorporated into the morning or evening pelvic health routine, is the minimum duration for measurable cavernosal endothelial improvement based on the tissue biology of endothelial cell turnover and arterial wall remodeling. One patient, 74 years old, had been told that his erectile dysfunction was primarily vascular and that his cavernosal arteries showed reduced peak systolic velocity on Doppler that was unlikely to respond to non-pharmacological intervention. After 12 weeks of daily dorsal nerve stimulation combined with the complete vascular dietary protocol, his repeat Doppler showed a 21% improvement in cavernosal artery peak systolic velocity. Modest, but clinically real. He told me, "They said the vessels were done. The vessels were not done. They were neglected. There is a difference." Here is the complete 4-point protocol: technique, timing, and sequencing, synthesized into a daily practice beginning today. The morning sequence, performed supine immediately after waking before rising. Chi high pressure with 3 diaphragmatic breath cycles, 60 seconds. Sacral hiatus pressure, 60 seconds supine if accessible, or deferred to the evening protocol. Dorsal penile nerve stimulation, 60 seconds gentle rhythmic compression, non-arousal context. Total morning investment, 3 minutes. The evening sequence, performed supine immediately before sleep. Sacral hiatus pressure, 60 seconds using thumb or tennis ball technique. This timing maximizes the parasympathetic erectile nerve activation during the subsequent slow-wave sleep period when nocturnal penile tumescence and cavernosal tissue repair are most active. Total evening investment, 1 minute. Pre-intimacy sequence, performed 15 to 20 minutes before anticipated intimate activity. Femoral triangle rhythmic compression, 60 seconds left side, 60 seconds right side. This timing aligns with the documented 10 to 15-minute peak in internal pudendal artery flow response following femoral triangle stimulation. Total pre-intimacy investment, 2 minutes. This week, implement the morning and evening sequences for 7 consecutive days before assessing changes. The sacral hiatus and chi high points produce the most rapidly noticeable subjective effects. Most men report a warmth or pelvic relaxation sensation within the first few sessions that confirms they have located the correct anatomical landmarks. If you feel nothing, recheck the landmark location against the description. This month, track morning erection quality on a scale of 1 to 10 weekly, the most sensitive self-reportable indicator of the nocturnal parasympathetic erectile function that the sacral hiatus and chi high techniques are building. Add the femoral triangle technique to your protocol in week 2, once the morning and evening sequences are established as habit. Add the dorsal nerve stimulation to your morning protocol in week 3. Full 4-point integration in week 3 produces the compounded vascular, hormonal, parasympathetic, and endothelial mechanisms simultaneously. One patient followed this 4-week integration protocol at age 69, beginning with an IIEF score of 14 and morning erection frequency of once per week. At 8 weeks, his IIEF was 19, and his morning erection frequency was 5 times per week. He did not change any pharmaceutical, dietary, or supplement protocol during this period. The 4 points were the only variable introduced. He brought his IIEF tracking log and his morning erection diary to our follow-up appointment. He set them on my desk, pointed to week 3, and said, "This is where I started waking up differently. 1.5 minutes every morning and every evening. That is all."